Hello, everybody. It's Tuesday night on the Dr. Boz Show, and we have a show for you tonight where you will learn what is it that you should be following to predict your risk of heart disease. Tonight, we're going to show you two examples of patients where they have very similar profiles on their cholesterol screening panels. They have dramatically different risks for having heart disease. When looking at your risk for heart disease, I do like to use the data from the Women's Health Study, where there were some things in the Women's Health Study that I'm embarrassed by, but the Women's Health Study had incredible, massive study of a population. And when looking at the risk for heart disease, if your age is 55 or less and your blood pressure is out of control, you have a 2.25 times higher chances of having heart disease. You have a 50% increase in risk for heart disease if your age was between 65 and 75. If your triglycerides are elevated, you have this increased risk for heart disease at both less than 55 years old, as well as, let's go back to that. I'm not quite down that slide. Hold on, go back here. As well as a risk if you're between 65 and 75. If you have an ApoB that's elevated, meaning above 90, you have an increased risk for heart disease, as well as if you're in the 65 to 75 range. C-reactive protein, BMI, LDL cholesterol has a slight risk, meaning if this hazard ratio was 1.00, it would be no difference, no change. So the higher this is away from 1, the greater this predicted heart disease. That's cardiovascular disease as defined by the Women's Health Study. It's that top line that we're going to have you stick around and learn from in tonight's show, which I will tell you, I have some great examples. The 3 I'm using to teach with, I expect from novice to physician level that is watching tonight, you're going to learn something. Welcome to the Dr. Boz Show. I am here. I just checked my numbers right before we went live, so I will show you them here in a second and let you know that I've done a pretty good job on my fast today. Let's see if I can get my numbers to show up for you without pricking my finger again, because I pricked it right on time and then I had a little glitch there and didn't start quite on time. Hang tight, hang tight. So we are looking at, there we go. 1.9 is my ketones and my glucose is 81. There you go. And just about 15 minutes before the show, it was 2.2 and 77. So we are a little bit of stress to add to the glucose. Thanks for checking in and telling me where you're from. Thank you specifically to the folks that showed up at the Pin Chasers this morning. That is the bowling alley right across the parking lot here, where we have a free support group every Tuesday morning at 8 o'clock. And by golly, we learn a lot of science and medicine at that early hour, but very much appreciated community group that is free. I host it and I answer questions, and I think I learn as much as the rest of the folks. We're going to get started right away on this lesson because I know that some of you, this will be a slight review, but even my team, as well as the Pin Chasers who get to hear me say things over and over again, all found this review very helpful as we progressed into what should you be paying attention to. And why do I care so much about teaching this to you? It's my call to action tonight that if you can take in this information, what you study on your own and show up at your doctor's office saying, "Doc, this is what my numbers are." Not only will you have the confidence that you're using one of the best metrics to predict your risk of heart disease, but your physician will learn something when the patient shows up saying, "Here's what I calculated on my own." All right, let's get started. The slides are going to take me at least 15 minutes. So if you've already seen them, you can fast forward to that part, but I would contend it is the best review as well. All right, let's go over here. And now we can advance those slides. Yes, when we are looking for the risk for heart disease, what we're really trying to guess is who has this big old pimple that's about to pop inside their blood vessels. This is what a heart attack looks like right before or right as it's erupting and causing the blockage of the flow of those red blood cells. Predicting that is no small task. It is not an easy process to say, gee, doc, what are the problems found in heart disease and how can I best predict if I'm at risk? And when you go in and get your lipid panel done, we know that total cholesterol now touted to be less than 200. But when I started my career 25 years ago, this was supposed to be less than 260, and then it was 230, and now it's less than 200. Your triglycerides are part of that profile. Your HDL is part of that profile, and your LDL cholesterol is also part of that profile. But I contend, especially if you go back and look at those hazard ratios shown just a minute ago, that is not what predicts the most important predictor of heart disease. What we're really trying to figure out is, does your LDL cholesterol a predictor of a heart attack or not? And as I've done this lecture several times on stage, I think it's the third time I've done it on YouTube, but it's been a few years, that what we're really trying to help you establish is how many of these do you have in circulation? How many lipoproteins? And specifically, are any of your lipoproteins, are they kind of circulating too long, taking up residency inside your circulation? As I go through these slides, I remind people that my picture over here is a two-dimensional circle where I cut it in half so you can see inside. Those structures inside with the red rhomboid tops and the three strings are supposed to be triglycerides. Those oval-shaped yellow structures are supposed to be the cholesterol. But if you were to look at this in real time, you would see a sphere. So this picture from the Cleveland Clinic does a better job of saying, yes, that outside part is the water-philic or the water-like substance that tucks the fat inside these lipoproteins. That's how fat gets delivered around, the fuel of fat gets delivered around your body without causing a blood clot. And that green structure that's wrapping around the back of it, coming all the way to the front, is a lipoprotein. It's how the cells know what's inside this sphere by signaling, is this an ApoA? Is this an ApoB? Is it an ApoB48? Is it an ApoB100? The cells can determine what's inside that sphere. So let's move forward with knowing that you've got triglycerides labeled there, you've got cholesterol labeled there, and you've got an ApoB labeled there. What I think is probably rather sad is that when you look at the cholesterol panel and you go in to say, doc, what's my risk of heart disease? Well, your total cholesterol is, they draw your blood, they look at your blood, hopefully 12 hours after you've fasted, no food for 12 hours. And what they're really trying to predict is how many of those yellow cholesterols were found inside your lipoproteins. So they pulverize it, they break it up and say, okay, here we'll put all of the cholesterol into one pile, and that's going to be our total cholesterol. The next thing, we'll put all the triglycerides in a pile, and then that's going to be the triglyceride number that ends up in your lipid panel. And then they can measure, although it's done more frequently than it used to be, they can measure how many ApoA, which really reflects your HDL cholesterol, and how many ApoB are present inside those pulverized spheres that we now are using for cholesterol panel. But I contend this is not going to get you the answer for what's your risk of heart disease. All right, so this lesson of how things move around your body is a little bit complex. The cartoons do help, and I am looking forward to the questions you have at the end that my team is waiting for you to type in. As you put those into the chat, I have my team sorting out which ones would be best accompanying this live lecture, and so we'll answer those at the end of the chat. So again, what we're looking for is which ones are the bullet, which ones do cause that risk of a heart attack. attack. When we look at chylomicrons, that's the first sphere that's formed actually in your lymph system, comes out in the thoracic duct into the circulation. But chylomicrons are huge. They take up, if I do the camera only, when I'm talking to my patients, I'll say chylomicrons are here, your VLDLs are here, and your LDLs are about that size. When we look at the transition and the measurement of this sphere of fat, the sphere of fuel that is found inside your body, especially right after you eat, it is 500 nanometers wide. It's huge. So not quite seen by the naked eye, but you can definitely see it under a microscope. That chylomicron is very large, but most importantly, that I think is often missed, is that it only should be lasting for about an hour. An hour after you eat, this chylomicron should have done its job, and its job is to deliver triglycerides to the body. So all these triglycerides get dumped off in rather short order, and now you have the first of our measurements. This is a VLDL. The VLDL is again, smaller unit, which also lasts for a few hours in circulation. It dumps off the triglycerides. And now that you've emptied out even more triglycerides, we call it an IDL. And the average size of that IDL is 35 nanometers. Again, that VLDL was 50, the chylomicron was 500. And now as we look at the next 3 or 4 hours, they will circulate around trying to find a home for those triglycerides. And finally, days after eating the meal, you can find LDL cholesterol, or the bad cholesterol, the size of 18 to 28 nanometers, an average of 23 nanometers is your LDL cholesterol. And you'll notice most of what's in that LDL this low density lipoprotein, this LDL, is cholesterol. You know, cholesterol is in circulation for times of an emergency. That when you put cholesterol, excuse me, I can feel my throat getting dry here. When you put LDL cholesterol in circulation, it should be delivering cholesterol to the cells that can't make it. But that's weird. Cholesterol is made by every cell. When cells are healthy, they'll make their own cholesterol. It is dangerous for a cell to not have its own cholesterol. This is a rescue mechanism. The triglycerides are the most popular fuel to pass around to deliver energy to these cells. And at the end of the lifespan of this LDL cholesterol, you've got a bunch of cholesterol left. We're going to recycle that back into the liver because it's not necessary to offer cholesterol in healthy people. They're making cholesterol from within their own cells. That's normal. All right. So yes, there's 2 to 4 days that an LDL cholesterol can last inside your circulation. And we know that when we look at the size line, that VLDL starts out, between 50 and 80. And then the IDL is 45 to just over 30. And that LDL is in the 20s. It is the size of these lipoproteins that predicts some of the most important metrics for saying, are you in store for a heart attack? Is a heart attack what's headed your way? And we're gonna summarize this by saying, when I look at the circulation of this fatty tissue, this fuel, how quickly you get this delivered to the cells that need it and then get recycled is a production of your insulin health. Okay, so here we have VLDL cholesterol. Again, this came right after the chylomicron. This is probably about 7 to 10 hours after your cholesterol, after your meal, or 2 to 6 hours. I couldn't remember. Thank you. 2 to 6 hours after your meal has started. And what you'll notice here is, I think I can go over here and not get disrupted. What you'll notice here is that VLDL cholesterol, when it first enters circulation, is big, but then it does its job. Then it delivers triglyceride to the muscle cells. And when it does that, it will now shrink. This exact same lipoprotein will shrink in size as well as recycle into the liver. You'll notice that a few of those VLDLs tucked inside the liver, and they are no longer in circulation. There are a fewer number of those present. As the VLDL sinks to a 45, we're now going to change the name of it to an IDL while we deliver a few more triglycerides, recycle some of those back into the liver. We end up with an IDL, which is this intermediate size. Again, we don't really talk about those in your panels. And we hopefully quickly, within 3 to 4 hours after your food consumption, well, that IDL turns into an LDL. And now, 2 to 3 days later, in a healthy person, this is what happens. It recycles, it offers a few more triglycerides to anybody still wanting a couple, and the size of that LDL cholesterol doesn't shrink too much before it recycles into your circulation. Recycles into the liver. So here's an up close and personal look at what happens when your liver is saying, hey, I think you guys have done your job. Those little catcher's mitts along the liver here are receptors for lipoprotein, classically known to recycle that LDL cholesterol. But in healthy people, you are recycling several layers of this, including your VLDLs, your IDLs, and your LDLs. So this is what would happen. They are in circulation. They kind of float down and run into the area where the liver receptors are able to pull them back into the liver cells and recycle them, starting all over. This is how you keep the particle count low in your circulation. Okay, so hang with me there. I do want you to notice, see that little fuzzy line right there? That's going to be much different in the slide coming up. And this is a protection. It's as if you're looking down the tunnel of an artery here, and there is a very squishy glycocalyx is the real name for it, but it's a protective layer that's allowing low amounts of trauma to come to those cells as the flow of blood continues down the line. Again, here's the look of VLDL goes to IDL, goes to LDL. That's very large very low density lipoprotein, then intermediately dense lipoproteins, and then low density lipoprotein. A terrible naming system, but that's what we've got. And it's the same particle. The particle starts out as a VLDL, and as it gives away its triglycerides, the name changes because the density of that lipoprotein changes. It's also got a different timeline. Those VLDLs shouldn't be in circulation very long before we call them IDLs, and IDLs shouldn't be in circulation very long before they're LDLs. And the quicker you recycle those LDLs back into circulation, the less likely you are to create the bullet, the stuff that does cause heart disease, that stuff we're trying to predict by the end of the show. All right, so here's the opposite of that. I just showed you what happens in a healthy patient. Well, what happens when it's not a healthy patient, when there is an excessive amount of insulin present? And the answer to that is that liver looks lovely right here. When insulin's been around, it is saying, hey, we don't have the space to offer to have too much sugar. So liver, can you hold on to it? So the first thing that happens in a high insulin state is your blood sugar was elevated, not terribly, but just enough for the body to say, hey, liver, can you hold on to this? And the liver says, yeah, perfect. I'll put it in storage over here. We'll call that glycogen. So it takes glucose, puts it into, a condensed molecule holding a bunch of glucose. And then when there's all the glucose parking spots filled in your liver, well, your body will take those carbohydrates, put them into strings of fat, and then turn them into triglycerides. Triglycerides give me, when I'm doing a recent lipid panel, an insight into how many carbohydrates in circulation over the last 3 days have you consumed. And when you consume too many carbohydrates, if you want the best way to make your cholesterol look beautiful before you come in to get your cholesterol checked, at least the traditional way, anyway, the triglycerides will be low if you keep the carbs low for the 72 hours before you draw your blood for a lipid panel. Okay, so once you have all the parking spots filled with glucose, and then it fills with glycogen in the liver, and then you have all the parking spots filled with some triglycerides, well, then the liver starts to make little droplets of fat. And this is when it goes from this gorgeous looking liver to kind of a gnarly looking liver, which is called a fatty liver. And as strange as that looks on this picture, it's very real to life that's how it looks. That liver profile, on a cadaver, it looks that weird. So let's move on and show you, all right, now if we're going to be in the business of getting triglycerides circulated, what happens when you have a high insulin state? Well, it is not the same. So here we have our VLDL. That's the lipoprotein that is right after the chylomicron. It's 2 to 6 hours in circulation, and you've got a really full liver. So watch what happens. As that VLDL is in circulation, it offers triglycerides to that muscle cell, but it takes a lot longer. And there's just not as that the muscle cell says, I'm full. I haven't used the stuff you gave me yesterday. Quit eating. We don't have space for this. And the liver is definitely not full, or is definitely overly full. And it offers the lipoproteins, instead of getting recycled, they're building up in circulation. So it does take time. We're now at 6 or 8 hours into this circulation, and the VLDL, well, there's just a lot more of them around because it cannot find parking spots for these triglycerides, but it is persistent. So it continues to try to deliver them. And finally, it's going to circulate a few more hours to get your IDL, that intermediate density lipoprotein, to offer its triglycerides. But what I want you to keep notice of is look what's in the wake of that lipoprotein. There are so many more particles in circulation because everybody's looking for a place to deliver their triglycerides. And this is where the problem begins. When you see the patient profiles of their cholesterol numbers here in a second, you're going to see how striking of a difference this is in people who have high risk versus those who do not, especially those who are on a ketogenic diet. So here you've got several days into this now where the size of that LDL particle is now getting into the 20 or less group. And unfortunately, the place that this causes the most havoc is that this isn't just once in life. This is months, years, and I contend even days, even decades of elevated lipoproteins in circulation. And when you say, well, what does that look like on your cholesterol panel? It does change what kind of lipoproteins are in circulation. So here we have that same diagram, but now we are going to do it in the setting of a high insulin state. So that liver is filled with glycogen, that liver is filled with triglycerides, that liver is filled with fat, and you've got these catcher's mitts ready to catch the cholesterol or the lipoproteins as it recycles it. But unfortunately, when the liver is that full, those catcher's mitts disintegrate. So as lipoproteins come along to bind in that parking spot, they don't get recycled very well. You find maybe 1 or 2 turns over, but the rest of them are just saying, where's all the receptors to recycle this? And unfortunately, in the setting of a high insulin state, the liver's full. The receptors have downregulate because the liver does not need any more fuel. Go find a different place for this. And unfortunately, that little squishy glycocalyx, where I said if you're looking down the tunnel of an artery, that lining, that protective lining, is something I can measure in your labs with a C-reactive protein, a cardiac CRP, a highly sensitive C-reactive protein. And when the C-reactive protein is low, meaning there's not a lot of inflammation, then you have this gorgeous, beautiful protective lining like you do right here. But in the setting of high insulin, the C-reactive protein melts away. And it takes months of a stable, non-inflamed blood vessel to regrow that. And the consequences of no protective lining, of no glycocalyx, of a high C-reactive protein, a high insulin state is these cells don't fit together as well. And out escapes our lipoproteins. So instead of going into the liver, they say, you know what? I cannot find anywhere to hang out. I'm just going to escape the circulation and we're going to go outside the blood vessel. Unfortunately, that's not a good idea. If you want to prevent heart disease, this is not where you park your lipoproteins. But that immune system comes along, tries to shoot cleanup, tries to remove them. This is where a coronary artery calcium score, this is the calcification find on the outside or in a coronary artery, is because your immune system said, what are you doing here? Get out of here. This is not where you belong. And as that response of your immune system comes along and says, well, let's clean it up, it can handle that if only a few of those lipoproteins escape. But if you have a massive influx for months, and I contend decades of high insulin, your immune system says, I can't keep up. And that's where this pimple comes from. Okay, so we are going to take a look at some of the lipoproteins or some of the metrics of 3 patients. So I want you to take a careful look at this at this slide. And now we're going to move over to a patient story saying, when I am looking at a patient and they come into my office, let's go over to this metric. Okay, so you've got a few things that I wanted to teach. This is my August NMR teaching file. And what I want you to take notice of is there are 3 patients on here. There is a light blue, a light purple, and a yellow. And when I look at the comparison of these 3 patients, I'll tell you that personally, I do not even allow them to talk about cholesterol until their hemoglobin A1C is controlled. So you'll see in line 3 here, hemoglobin A1C is that, what is your average blood sugar? What's the blood sugar been for the last 3 months in your life? Excuse me. And you can see in these folks, so let's just start with column D here is October of 22, and then there's November of 2023. Those initials are AB for Annette Bosworth. Those are mine. So that's my hemoglobin A1C of 5.1 and then 5.3. And in that setting, that meant my average blood sugar was somewhere around 105, 110. I want it to be lower than that. I want it to be in the 4s, but I'm human. As we move on to J, she also has pretty good control of her hemoglobin A1C. So her average blood sugar of 5.5 puts them in the 1-teens, like low 1-teens, and that 5.3 about 110, if I remember correctly. And then again, S's hemoglobin A1C is 5.2. So their average blood sugar is not terrible. I'll tell you that all 3 of these patients, and I had to pick from about 24 of them to say which are the best teaching cases. So we're trying to use the best teaching cases here. They're all on a ketogenic diet. So they have low carbohydrates. They've really lowered their hemoglobin A1C. And I'll tell you that is first and foremost for what we are looking at to reduce their insulin, decrease the risk of heart disease. If you go back to that hazards ratio, you'll notice, yeah, hemoglobin A1C is a very good predictor of do they have heart disease? Are they at risk for cardiovascular disease? All right, second thing that I look at is triglycerides. So the hemoglobin A1C lets me peek at what is their risk of, or what is their control of their blood sugar for the last 3 months. But when I look at triglycerides, I gave you a hint about this earlier in those slides, that the triglycerides are a measurement of how well they've controlled their carbohydrates in the last 3 days, in the last 72 hours. So you'll look at mine at 88 or an 82. In a perfect world, it should be closer to 50, but I'm not perfect. I would love my my triglycerides to be 50, and I have several of my patients who do a much better job than I do. But then we move on to Jay, who in February of 2024 was really trying to cut down her carbohydrates, really doing a good job. But after a couple decades, like 20 years of elevated insulin, her triglycerides, boy, it doesn't take even but a small bite of roasted nuts. I mean, the simplest of even ketogenic foods sends her insulin rising, her triglycerides will be high, and her ability to offload triglycerides from those lipoproteins is compromised. So in those last 72 hours before her before her test, that 199, I mean, we want it less than 150. So it's not as good as we wanted. And as we talk about that, show her, do not have any of those little even keto snacks right before your cholesterol panel. I'm trying to judge how well you move fats into storage. And she was not keeping up in February of 2024. She was way better, but this was than the other metrics we had on her. But it wasn't great. And so then just recently, in the last month or so, in the last actually couple week or so, she has had a much better reduction in her triglycerides, but it's still not great. I want those triglycerides to be in the 2 digits, not in the 3 digits. And even if she had zero carbohydrates in the 3 days before she came to see me, her ability to offload triglycerides is blunted. Something's wrong. Something's not right. So as we look over at S, again, her A1C, controlled blood sugar over the last 3 months, triglycerides of 73 say, yeah, she's doing pretty good. She really is offloading her triglycerides pretty efficiently. The next thing I want you to hop down to, you will notice uric acid there, but we're not going to dive into that there. I do think there is a big lesson to be learned. How long has the trash been stirring in folks? And when they're trying to get rid of that excessive uric acid production, it's a bugger. But this is that C-reactive protein where you look down the tunnel and say, how much inflammation is there? Again, mine has always been very low, not always, but in recent years been very low. And as we look at that struggle that people have when inflammation is just, it is present. We can see it in that C-reactive protein. The next thing we're going to talk about is that ApoB. We've only got 2 numbers in this column for that because it is something you specifically have to ask for when going to your doctor. But the most important thing I want folks to look at is down here in your NMR. So NMR is, let me just go back to this. I want you to look at some of these numbers here. Your lipoprotein, this is a particle number here on line 11. We are then going to look down here. What is the small LDL particle size or particle numbers? How many of your small LDL particles are present? The LDL size, I mean, if it gets too small, remember if I said if it gets into the 20s, it's going to sneak through those openings and have a higher chance of exiting circulation the wrong way, not being recycled in the liver, but getting into the skin layer of your blood vessel. So I want you to just take a look at that. I'm going to show you these numbers on the slide deck here, and then we're going to come back and look at the things I haven't that are not quite on there. So here's those numbers again. You'll notice over here that LDL, that's purple. That's where the bullet is when you are trying to predict who's going to have a heart attack, that small, dense LDL. So what we do not want to see is that when people come in to get this cholesterol checked, when they get an NMR checked, they have been fasting for at least 12 hours. I mean, I hope you get closer to 16 hours when you do a cholesterol panel. And I really hope you do not eat after like 3 o'clock the day before. If you have been around the sun 50 times or more, if you're 50 years old or older, for heaven's sakes, do not eat after 3 o'clock the day before you get your cholesterol checked. All you're measuring is your insulin resistance then. Maybe that's what you want to see. But if you're trying to get an honest number of how well can you offload the energy in your lipoproteins, for heaven's sakes, don't eat after 3 o'clock. But what you don't want are the ends of this spectrum. So you haven't eaten in 12 to 16 hours. Your VLDLs, you should have no chylomicrons, but your VLDLs should not be anywhere close to 80. They should be closer to the IDL part. You should have only a few of them left in circulation because they're only supposed to last an hour. So if you're keeping them in circulation for 16 hours and they're still really big, it tells me you are not getting rid of triglycerides. You're not offloading the fuel that should go to the cells. The other thing I don't want to see is I don't want to see a lot of really tiny, you can't see the number because my head's in the way, a lot of really tiny LDL cholesterols. By the time you offload that fuel and it goes from the VLDL to the IDL and the LDL, we do not want to see a bunch of particles. We want to see those LDLs recycled back into the liver, and we do not want to see them smaller than 20.5 nanometers. So let's take a look at that. Here are some metrics that, and get my head over here, a VLDL particle size. So this is one of, I don't know if this is my current one. Let me see. VLDL particle size. VLDL. Oh, yes, this is one of mine. So 41.4 is what one of mine is. You'll see that in a second. And so when we say, where does that land on the spectrum? A VLDL, it's not 80, thank goodness. And it's not in the 50s. You know, I don't think anybody's is, well, let's hope you've never seen one in the 80s. But it shouldn't be in the 50s. It should be in the low 40s. So I had a few VLDL particles in circulation when this blood test was drawn many hours after fasting, and the size of my VLDL particles was smaller, meaning I was getting rid of insulin. We're going to compare this to the other patients that were in the profile. We'll come back to their chart in just a second. But let's just look at that LDL particle size. LDL particle size, again, we want them fluffy. We do not want tiny little LDL particles. They are the ones that cause the highest risk for heart disease. And I contend it's a way better predictor of whether or not you have heart disease or are at risk for heart disease by what is the size and number of these little turkeys in circulation 16 hours after the last meal. So 21.5 is what mine was. Again, a very nice, healthy sized, low density lipoprotein or bad cholesterol. So as you look at the spectrum for insulin resistance, well, we're going to come back to that in a second too. Let's go over to our metrics here. Okay. So let's just remind you what we're looking at here. We've got these are the NMR profiles. Make this a little bit wider for you. NMR profiles of our patients. So here we're going to start with how many of the LDL particles were in circulation 16 hours after you ate. And the gods, the people who write the rules for this said, yes, you should have less than 1,000 LDL particles. And I will tell you, I take care of ketogenic patients. I never see this below 1,000. But is that the predictor that they're going to get heart disease? Well, if you go to the traditional rule book, it says, well, yes, if you have more than 1,000 particles in circulation, you should be taking a statin. You should be taking a PCSK9 inhibitor. You have too many particles present. Now, I'll remind you that that ApoB was checked, and we do like the ApoB was that green tag around the outside of that sphere, and it's looking at how many particles were present at 16 hours. And I did an ApoB in October of 2022, but I forgot to do it in November of 2023. So I have one metric, and it is. I mean, I would love it lower, but it's less than 90, which is like the cutoff to say, yeah, if we can get it under 70, I really like that, under 70. But is it really that important? And I there is a huge debate that says when you're in a ketogenic state, you are moving fat to your cells. The question is, and how many particles does it take to deliver the fat? The question is, how long do they stay in circulation? The other word for that is, how long is their resident time in the flow of your blood from the time where you eat, you package that fatty fuel to be delivered, and then how long does it take to get recycled? And it's in these numbers that we can see that. So let's start with mine first, 1500-ish on both of those. But let's go to Jay. And remember, Jay had a higher blood sugar, has a higher C-reactive protein. And indeed, her numbers are greater than we would like. This for some reason cut off at 2,500. This one was 2,800, but I would contend she was probably at 3,000 before more than 3,000 on this one. It's just that the machine doing it that day was only going to go that high. Her LDL cholesterol. I mean, remember, LDL cholesterol should be less than 100 now if you're at risk for heart disease. So says the American Heart Association. And every cardiologist out there says, yeah, you got to get that LDL high or LDL under 100. And when it's high, we're going to use medications to reduce that. end with just looking at S before I go to the next metric that I'm really looking at. So the number of LDL particles in S is 2,000. Again, twice as many as what the guidelines say. And indeed, her LDL cholesterol is twice as high as the guidelines would say. Remember, she had a nice A1C. Her triglycerides were better than mine. Her C-reactive protein is low. Her trash count, meaning her uric acid, is very low. She has really low risks according to that. But when you look at that lipoprotein, you're definitely getting your hairy eyebrow from especially traditional approach to cholesterol. So the next place I want you to look is the small LDL particles, meaning, so you've got the VLDL particle size. Let me find it. VLDL particles, large VLDL particles. Let's see if I can do one thing here. Go back here. Go back here. Let me just show you this quick. So again, VLDL particles, if they're large, think of the 80 to 55. If they're large, we're looking for this to be very low. So we go back to these metrics and say that large VLDL particle number, we want it to be less than 2.7 millimoles per liter. And indeed, everybody made that list. Everybody was able to empty out the biggest, fattest lipoproteins and get most of the triglycerides off of that. The second place we look, though, is 16 hours into this fast. Now, again, remember, LDL particles can last several days in circulation. We want to know how many of the small LDL particles are in circulation. And the metrics are recommended to have them less than 500, less than 527, but just think of it as less than 500. So in my case, and again, back over here looking at this, how many of your LDL particles, how many of the tiny ones were in circulation? And I contend when there's more than 500, you're having trouble getting them recycled back up into the liver. So in mine, we had a 90 for the October of 22, and a year later in November of 2023. In fact, so low they couldn't measure them. There were very few LDL particles in circulation. But had you just looked at my lipid panel, it was 155. Again, something worthy of a statin if you were in a traditional approach to cholesterol processing. All right, so now let's go on to the J patient, where her lipoproteins were 1,000 of the small, so twice as many as we want of those small LDL particles. Again, S is less than 90, but what is very interesting in this case is when I tell you that J has... she's doing her best. She's in a ketogenic diet. She's doing really well, but her physician is very worried about a heart problem. So it was in this season, I think right before this or right at the time of this February 2024, where she was started on a statin and a PCSK9 inhibitor. That's that injection that cost about $1,000, and it really helps you clear the lipoproteins out of circulation. So let me just clearly make sure you hear this. That patient with the highest small LDL particles of the three of us is on the maximum treatment that we have to offer patients to sweep out those particles out of her circulation. She's on a statin, which keeps those little catcher's mitts waiting for the removal of LDL particles. And she's on a PCSK9 inhibitor, which is it's like an immune system that's going to gobble up the particles and remove them from circulation. And by golly, it does an amazing job. Like I'm actually impressed that she went from this LDL particle number, this LDL particle number that was greater than 2,500, something so high we couldn't measure it. Now she's in the measurable range on the PCSK9 inhibitor and the statin. And here, her particle number for the small LDL particles was 1,000, and 6 months on an aggressive treatment plan on a ketogenic diet, and she has still higher than desirable, but much much better, much closer to the part that we want reduced. What I think is key here is to go also to the LDL size. Again, we do not want anybody to be in the 20s. We would like them all to be 21, and if you could get them to, I don't see very many in 20 at the size of 2022, but S is almost there. She has 21.9. So she has large, fluffy LDL particles. And really, I've got the worst one, where the particle size, I don't have a lot of them, but they do get pretty empty before they got recycled. So where am I going with this? What is the number one metric for deciding who's at risk for heart disease? And why can I say at the beginning of this show that I've got two patients, and they have very similar, meaning 245 LDL cholesterol, 205 cholesterol, and their lipoproteins have lots of similarities, but it is this score, something called an IR score, that really helps to separate who's at risk for the cardiovascular disease. So again, my number 25 in October of 2022 and 26 in November of 2023. Again, I'm not perfect. Having it less than 25 is the goal, is something I wish, I like mine to be less than 25. At 45, you are at the 50 percentile. So half of the population is worse than that. Half of the population is better than that. What is this IR score though? It is a compilation of all of these metrics put into a mathematical equation, essentially, to say how much would we weight the fact that their LDL particle number is 1,500. It's not the end all be all. It's one metric. If the LDL particle number is 1,538, but the size is 21.1, and the number of small LDL particles is less than 100, less than 90, well, that mathematically turns into several decreased risks. And that insulin resistance score of 26 and 25, and here for S, again, 25. When we go to J and say, well, look at that, her LDL particle number and her amount and the size and the number of smalls, it is all influenced by what is her resistance to insulin and how well can she offload the triglycerides out of the particles into the body. And her risk is 48. So she has, in February of 2024, she is in the percentile that is higher than 50%. So let's say she's at 52 percentile. When she's at 42, she's now at, 45th percentile. She's has a better, a lower risk of heart disease. But what I want to drive home is the next picture. Let's go into, let me go here and go here, that we are here. Go to here. So we are looking at that lipoprotein insulin resistance score, where the lower the number, the more sensitive to insulin you are, the higher the number, the higher the risk of heart disease. Just looking at the number from my numbers is less than 25. But I think the more important thing is to look at that hazard ratio, that risk of what's your risk of heart disease. And calculating this risk of heart disease is, it's no small task. There's actually calculators out there for LPIR. The only way that you can get the numbers to calculate your LPIR is to have a nuclear magnetic resonance. You can't just say, doc, check my cholesterol. But I contend it's $75. You should order this yourself. Own your labs. We'll give you the link in the show notes to to order it yourself, and show up to your physician with your LPIR score, because you'll notice here that I filled in that top blank. That LPIR score, if you are less than 55 years old, your risk of heart disease, the higher your risk, the higher your LPIR score, a 6.4-fold increase 6 times more often will you have a heart attack. Meaning if you get that LPIR score low, the ability to prevent heart disease is in that score. When you get over the age of 65, so again, less than 55 and then over the age of 65. So there's a gap in there where it's no man's land. But you'll notice the trend that your hemoglobin A1C was measurable. LDL cholesterol was exactly the same. Body mass index was was actually a better predictor of heart disease than LDL cholesterol and A1C. C-reactive protein was a better one than the LDL cholesterol. ApoB, again, that's the how many particles are in circulation. It's kind of like a poor man's assessment of an NMR. Your blood pressure, incredibly important. Again, the younger your blood pressure goes awry, the higher your risk of heart disease. And finally, if you can get that LPIR score, what is your lipoprotein insulin resistance score that you can only calculate by checking an NMR? If you walk into your physician saying, this is my LPIR score, I know, doc, that you're worried about my LDL cholesterol, but the hazard ratio for my LDL cholesterol is only 1.3. The same as what it is for a hemoglobin A1C. Whereas my reduction in my LPIR score is a significantly more impactful number to manipulate. And the way you manipulate that is not the same as reducing your LDL cholesterol score. Okay, wow, that was a lot of information, and I am super curious to see if I lost my audience here by looking at your questions. My team is getting those ready for you over on the other page, so I will just give them a second to get that ready. But I do want to say that this isn't the cliff notes to say, hey, you don't need to worry about your LDL cholesterol. What I'm trying to show you is patients say, doc, what is it that I need to do for my LDL cholesterol? And I contend that the cholesterol, it needs to be understood to this level of complexity in order for the patient to get the advantage. And when they know their lipoprotein score, when they know their the size of their particles, how many particles are in circulation, and they go to their physician, that doctor pays attention. As much as you think, oh, they don't want to look at that. Well, if they don't want to look at that, you should find a different doctor. But the majority of people that I know in this space, when a patient presents with this level of data, a hazards ratio that is that much better at predicting heart disease, when you walk in knowing that, and you have your score printed out, even if you're on Medicare and you say, I don't want to pay for it, I want Medicare to pay for it. Here's what happens. You go to your doctor, and the doctor, showing up with the results is a way easier sell to say, I want you to repeat it in 6 months. Will you help me follow this? And then watch that doctor be attracted to this level of understanding. So I will hop over to your questions now and see how we're doing. I don't know if you noticed, but before we went live on this show today, we did put a post out there on YouTube saying, what are your LDL or what are your cholesterol questions? So between the questions we've got coming in on the live show and those on the post, we'll see if we can get them answered here. All right. So we have Diana S. So would it be best to fast 72 hours before getting your lipids checked? Well, Diana, this depends. Let's see if I can do this. Does that work? I don't know if that works. I can't get it to do what I want it to do. Sorry. 72-hour fast before a lipid profile. Well, I'll tell you, there's a couple of caveats to that. You would have a great triglyceride if you're on a traditional traditional American diet, meaning if you're used to a lot of carbohydrates, if you're trying to get your doctor to not write a cholesterol medicine and you want your triglycerides to look good, getting those triglycerides down, it's a really important part of the prediction. When you're on a ketogenic diet, 72 hours of fasting means you are moving fat around that body, and you may find a higher amount of triglycerides at that 72-hour mark. The efficiency at which you can move fuel is what you're looking at on an NMR, and you have a very clear picture of it when you do those, when you do a lipoprotein NMR. But if you're just doing a cholesterol panel, you'll be able to manipulate the triglycerides in 72 hours on a standard American diet. But for a ketogenic patient, you can actually see that they are now, they're moving fat out of fat cells because they're fat adapted. So the amount of triglycerides in circulation is higher. So the answer isn't as clear as if you would have asked me this 8 years ago, before I was really very much better versed on what happens when patients fast. I would have said, well, yeah, you'll get a really good triglyceride if you fast for 72 hours. And people not on a ketogenic diet, that's true. But that's not true for my ketogenic patients. They are really moving a lot of fat by the 72nd hour of fasting, and it just skews what we're looking for. You sure as heck don't want to measure uric acid at 72 hours of fasting, because you're moving a lot of trash out the door by that time. And although that's good for the overall health, if you're trying to make your uric acid look good, it's not going to look good at 72 hours. Okay, next question. Let's see if I can match a little bit better. Diana says again, getting my numbers checked in 6 weeks. Should I eat Oreos the week before? That's hilarious. So this refers to Nick Norowitz. He is a 2-time guest, probably the only guest I've had on here twice, who is he is a lean mass hyperresponder. And so he's been on the ketogenic diet. He's reversed his inflammatory bowel disease by being in the state of ketosis and removing inflammation. And his particle number is very high. I mean, his LDL cholesterol, mine was 200 and something. His LDL cholesterol is like 500, I think. So he is just moving a lot of fat around. He runs like 30 miles a week. He is got, very little fat on his body. And when he took in a high amount of sugar, it really slammed down the movement of fat, because he had carbohydrates available, which he usually doesn't do. So by being in a constant ketogenic state and then quickly shutting down the movement of fat by adding a whole bunch of carbohydrates, yes, it does make the ketogenic profile look, it does decrease the LDL cholesterol in a ketogenic high or lean mass hyperresponder. But I would not do that. I would not do that. I mean, the other part is Nick Norowitz is able to check his LDL or his lipid profile a few times, and even he said it's really interesting how much it can change within 12 hours. So you're gonna give your doctor a coronary heart attack if you do that, Diana. But it would be entertaining. Aloha 22. He is a regular on he or she, I can't remember, on the channel. My A1C is 4.5. That's really good. That's a blood sugar in the double digits. My ApoB is now 111, which we love it to be less than 90. You'll hear folks like some of the experts say if you can get in under 75, it's even better. But last year her ApoB or her ApoB was 107, and LP little a is now 57, was 27, or 57.5 was 27. How does that happen? How do you reduce it? So here's the truth about that, Aloha 22. I actually had the LP little a on the hazards ratio, but it didn't fit on my slide. It is one of the other metrics that it was actually under, I think it was below the LDL cholesterol and what was the other one that was at the bottom? Oh, body mass. Oh, hemoglobin A1C. That's what was it. LP little a is a genetic risk factor. You should only check it once. It will fluctuate between, like what in your case, it was a 27 to 57. It'll fluctuate, but it's the same thing. I'm pretty sure the cutoff for LP little a is like, I want to say it's 75. And so when it's above that, we make one decision. When it's below that, it's another decision. So that yours shifted in that 27 to 57, it doesn't really mean anything. There is no way to change your genetics. The most important thing for when patients have a positive LP little a is, yes, you should all check it once. And you actually have to order it that way. If you push in lipoprotein A, which is usually lipoprotein A1, that is not the same thing as LP little a. LP little a is a genetic risk. It's like a flag gets put on your lipoproteins and they can't recycle as quickly. But you either have it or you don't, and there is a much higher incidence of calcification of one of the valves of your heart if you have that genetic risk. So if somebody has a positive LP little a, in my practice, we just make sure that there's been an echocardiogram looking at that valve, making sure the valve is not calcified. If the valve isn't opening and closing as beautifully as it should, we do have that followed by a cardiologist, because if the aging, so it's like the aging process for that valve is on hyperspeed, and that hyperspeed of aging can't be reversed. At least in today's pharmacology, there's nothing out there that changes the lipoprotein A. There's some theories about how to fix it, but that's not on the market yet. But what you can do is you can watch the aging of that valve. And if it starts to calcify, if there are problems with it, my goodness, there's some amazing things that they can do to keep that valve functional, keep you with your own valve as long as possible. Do not let it calcify and get into heart failure, which then requires a heart transplant if you want to live. So again, when people talk about their lipoprotein A or LP little a, definitely, I mean, checking mine, I should make sure I got the functional range of that. LP, oh yeah, less than 75. Let me just show you this. I did check that on all the folks of our in our study here. So mine was less than 8.4. The J one is more than 75, and the S one was more than 75. So they both have this genetic risk that their LP little a is elevated. So you're not alone. It's not uncommon, but there's nothing you can do about it except to monitor that valve as you age. Having LP little a doesn't mean you're gonna have a valve that stiffens up and gets calcified, but you are at higher risk for it. It's a really good question, and it's something that, again, we need patients educated on it so they can bring it up to their doctor. Okay, let's go back to this. That was a really good question. Aloha. Lisa, oopsie, this is the way I wanted to do that. Questions over here. Lisa writes in and says, if I have a 0 CAC score but high lipids, do I still need to be concerned about the high lipids? Well, I'll tell you, Lisa, the key to that question is I would be looking at your LPIR score. I know that was the whole point of the video, but it truly, one of the reasons I get this question so much is I have this that's going right. I'm on a ketogenic diet. I don't have any calcium on my CAC score. I remind patients that a coronary artery calcium score, it is an easy, great, cheap way to look for calcium in your heart. Is there calcifications in the arteries that are leading to your heart? Much like those little lipoproteins went outside that cell or outside that hose, outside that artery, and then the immune system came after it, and you could see those little white dots on my cartoon. Those white dots are calcium. That's the response of your immune system to clean up lipoproteins that exited the circulation. But that CAC score misses 1 in 5 of calcium. So the interval between those images on a coronary artery calcium score, they're not tiny. If you have, there is a CT angio, which is very thin slices through that coronary artery and is not likely to miss calcifications in the coronary arteries. But 1 in 5 of the calcifications are missed in a coronary artery calcium score. So a coronary artery calcium score of 0, when they compared that to a CT angio, they missed 1 in 5 that had a significant risk, enough to put them in the profile of, I think it was above 50 on the CAC score. So Lisa, I know that it feels good. I like that my CAC score is 0 as well. And I do have, a high particle number in my profile. The number of circulating LDL particles is high. It's above 1,000 in me. And so you could say, am I at risk? What I really want to know is how long do you keep that lipoprotein in circulation? And when it's been circulating for too long, that's when things shift. That's when that little fella that started out to be this wonderful source of fat nutrients in your body cannot get to where it's going, or it gets stuck in circulation and can't get recycled, at which point it exits the side door, which is outside that circulation. So you can't guarantee that it's happening with the high lipids. What you can be a lot more confident in is when you have this, when you have your LPIR score of 25 or less, you're moving fat very efficiently. When it gets above 45, which is where patient J is, I'm more concerned. When you can keep it low, you've got a pretty good argument to say, yes, I know my cholesterol is high or at the time of that test, but those particles are on the move. Much like our lean mass hyperresponders are using that argument to say, it isn't so much that their particles are high, it's that they're high and they aren't recycled efficiently. And it's that recycling process that we're trying to help patients with, as in patient J, to see, can we improve their risk for heart disease? All right, got some other good questions. I know I started a little bit late, so I'm trying to make sure I get through all the questions because I do appreciate them. They are good too. Oh, I wanted to do it this way. All right, Bonnie writes in and says, okay, why is it so hard to have our medical professionals order blood panels outside what they normally order? Is it because medical insurance doesn't cover those tests? It's very frustrating. Well, Bonnie, I'll be honest, it's been a learning curve for me as well. When patients come in and they ask for tests that I do think are inappropriate, like I'll have patients come in and they want, they have had a friend die of cancer, so they want every cancer marker tested. And I am careful not to do that. Like, you are opening up a bag, though, even if you carry a marker, it doesn't mean that you're going to have that risk. So I get the hesitancy of rushing in to be the doctor ordering tests, because once they come back, the doctor has to know what to do with them. But it is the future. This is what will happen in the next generation, that unfortunately, or maybe fortunately, they're going to have to be better educated. Whether that's on YouTube channels like this, or that it's like minimum viable product to get insurance, you're going to have to understand your own labs well enough to be able to process them. That responsibility on the medical profession, it's terrible. We're doing a terrible job. We're not making nearly enough time to educate the patient on what to do about it. I mean, it's one of the places where our show, I try to be that for my colleagues, that I know not everybody can take time to do it as we do this week after week, trying to find the content that really matches with what the audiences want. But I know that if we have enough physicians out there in the education lane, trying to keep as much of it free to the public, we need the public to be aware. That's the only way we're going to move the needle on a very unhealthy medical population. But it requires the attraction of patients to want to know, why do I want to know what my coronary artery calcium score is? And when I know it, is it a death sentence, or is it, I'm free in the clear for 10 years, which is, I've said those words when I first started studying coronary artery calcium scores, and I've since retracted, saying, not quite. Let's look at some other ways where we can better predict the risk for heart disease. So let me give you the advice that I tell my family members that don't live near me, and they want to, say, well, can you just check my labs and do this? And I said, sure, we could do that, but it really cripples you when it comes to your physician. If you do a few labs, and again, in the show notes, we will put the link to Own Your Labs, OYL, Own Your Labs, which really is just a subcontract with LabCorp to get things like an NMR done. And it's not cost prohibitive. It's like $75 to get that lipoprotein done. And what happens is, instead of walking into the doctor saying, hey, I need you to do this, how much is your time worth? If you can go in and say, doc, I'm seeing you next week, and this is my lipoprotein. I'm going to want to talk about this in our visit, and I just wanted to give you a heads up that this is what we're going to be discussing. I had patients do that all the time when I had a full panel of patients, and I loved it. It helped me serve them well. And it was just a better day when the patient was engaged in what their risks were, and then really wanting my expertise to improve it. So the reason it's hard is, well, no doctor likes to be embarrassed that they don't know something. If you've ever met somebody in medical school, they're nothing if not competitive. That's how they got into medical school. And yeah, there's a little bit of humble pie there when even when I have things presented to me and I don't know what they are. It's very humbling. All right, let's go on to Lisa. With poor liver health, okay, will poor liver health stop the recirculating of cholesterol? Will supporting the liver health help? So the key to that liver profile that was in the cartoon there, if your liver stops recycling lipoproteins, you're dead. That you can't stop it. That's liver in Latin means life, and liver is not only the churn of much of our energy, it is the barometer for how well you're living. When the liver health is impacted, what I'm always impressed by is how quickly that liver can heal. You decrease the tax on your liver, which means stop the alcohol and decrease the carbohydrates. And it is powerful how many people can come back from the edge. You know, when I was in training, there was my favorite section of the hospital was shock trauma. And so you would have patients present in shock. And not an uncommon problem was an overdose of Tylenol, where they had taken so much Tylenol it shut down their liver. And it was always interesting to me. Tylenol is removed by your liver, but ibuprofen is removed by the kidneys. And when the kidneys got stung from an overdose of ibuprofen, boy, they had a hell of a time coming. I mean, dialysis and kidney transplant was almost always the path they ended up on. But when the liver got stung, and again, the numbers were astronomical, like it was an attempt of suicide, where they took this large dose of Tylenol. The liver is just swollen. It's boggy. It doesn't even look like an organ. It looks like this moth-eaten, swollen thing on ultrasound. And I was floored the number of times that the liver came back to a fully functioning normal liver within 2 weeks. So the liver is incredibly resilient. It deserves the Latin term of life. When the liver makes it, you make it. If you've got poor liver health, if you've got elevated liver enzymes, cut out the booze, cut down the carbs. You can't believe the number of things that get better. Let's see if I can get through the rest of the questions, because I think there's some still pretty good ones. April wrote in and said, what does an LDL of 194 suggest? A sister-in-law said it should be 99 or less. Recently on statins at 38. Oh my goodness. And statins concern me. Your thoughts? Is there a gene testing for more specific taking statins? If so, which? So key thing there, April, is I would be getting if those are your labs, your sister-in-law said it should be, okay, so your sister-in-law is telling you about your labs. An LDL of 194, if you go back to our little list here of what is the LDL cholesterol within our three little patients, let's see. Oh, there it is. Go to here. So here is the LDL cholesterol in all of ours. So mine was 155, 152. Jay's was 245, 313, and S's was 204. Again, all of them are high. If you're on a ketogenic diet, you're moving fat around. That LDL cholesterol is going to be high. What we are trying to kind of condense into a punchline is, how long does it take from the time a lipoprotein starts in circulation to the time it gets recycled back into the liver? And the answer is not always, oh, it's obvious. This LPIR score found in a lipoprotein, found in an NMR test that you can do at Own Your Labs for about $75. That really gives you the answer that you're looking for. Just looking at LDL cholesterol, it's like, I feel clueless. I mean, people ask me advice on their cholesterol all the time. I'm like, I mean, it's not fair. I start with an A1C. If your A1C is way off kilter, I don't even look at your LDL cholesterol. You have to fix your blood sugar first. So that's the 3-month report card of how good your sugars are. The second part that we look at is how many triglycerides do you have in circulation? And if you're still consuming too much consumption, especially of foods that are getting converted into triglycerides, which include carbohydrates, but also can include protein. This is one way to measure, are you consuming more protein than you should? And that is when you fasted for the 16 hours that you were supposed to do before a lipid panel, were your triglycerides in the triple digits or the 2 digits? It should be in the 2 digits. It should be less than 100. The closer to 50 you are, the healthier I think you are. That's for triglycerides, not LDL cholesterol. But once those two are in normal levels, then we can talk about the what to do about that LDL cholesterol. Okay, next question. Oopsie daisy here. Last question. Why is my cholesterol worse when I fast longer, like 48 hours or less before the test? So I think I covered that. In essence, if you're in a ketogenic diet, you are moving fat, which is good, but it also is it's not as easy to explain to your doctor. Last question. Does omega-3 fatty acid in sardines in water get rancid if we dehydrate them by adding olive oil afterwards? Okay, does omega-3 fatty acids in sardines in water get rancid if we dehydrate them by adding olive oil afterwards? So I think what you're doing is you're taking a can of sardines in water, you're pouring off the water, you're putting in the olive oil, and then you're dehydrating them? Or are you dehydrating them by adding the olive oil? The punchline is rancid sardines, I don't hear much about. I do hear seed oils going rancid. Olive oil is technically a fruit oil, but it does have a shorter shelf life than a lard or a saturated fat. Personally, when I am looking at how I eat my sardines, I open the can, I pour I buy them in oil. I pour the oil over the dog food, give it to my dog. And then I put some really good olive oil back on top of it, mash it up into my sardines and eat it that way. I don't know if I answered your question. All right, what I would love to hear is if you learned something from this. Again, we at the Dr. Boz Show do our best to offer you as much free information as we can. The way you can support us is to go over to bozmd.com, take a look at the platform there, use that as a way to support us. And it is my pleasure to see when folks tune in live on Tuesdays. So thank you for joining in, and I hope to read your comments about your other questions about cholesterol. We'll see you next